Okay, this presentation is specific to NSCA Essentials of Personal Training, Chapter 9. Still talking about client consultation and health appraisal, but now in presentation 3 here, we're going to get into the evaluation of coronary risk factors, disease and lifestyle. This is stuff that we've seen in like Kinesiology 231. For this presentation, we'll be talking about cardiovascular disease risk factors, identification of medical conditions, and diagnosed disease, and also lifestyle evaluation. As you're sitting with your client and you go through their information, you'll start to utilize this table that we've used in chapter 9 before, where it's at 8+1 or 8 and 1 format. Now, this may look familiar to you. I know we've done a ton of case studies based upon this, but you have to remember the top part of this table, these 8, 1, 2, 3, 4, 5, 6, 7, 8 items are positive risk factors. If anybody at the table has this, it's a positive risk factor, meaning it makes it more likely that they'll have cardiovascular disease. It's very much like saying, if I want my car to go faster, there's a positive correlation between going faster and stepping on the gas pedal of my car. So for example, if your client sitting across the table from you is male, but is 35 years old, that would not be a positive risk factor. But if they were male and they were 65 years old, then yes, that'd be a positive risk factor. So as you go through these, you start to pick these out from the health history questionnaire, and you can come up with how many positive risk factors are present. And then conversely, there's only one negative risk factor, and I stress this all the time in our homework assignments. If they have high density lipoprotein that is greater than 60, that would be a negative risk factor, meaning you're taking a point away. So a person might be 65, male, that's a point. They may have had a family member who passed away before 55, that's a point. Non-smoker, and they don't meet any of the other ones, so they have 2 points so far. But because their HDL is above 60, that would take 1 point away. So their net would be 1 point. So you have to think of it in terms of you have 8 possible points up here, and you have 1 possible negative point down here. Meaning a person, when you sit at the table, you're adding these up, and then you're coming up with the net amount between the positive and negative risk factors. All right? Who said math wouldn't be used when you got older? Holy cow. So with the cardiovascular disease risk factors, it's that 8+1 format, and I talk about the positive and the negative when you look at these. And a positive risk factor may be like an attribute or an exposure that is associated with an increased probability of a specified outcome, such as occurrence or disease. And with this, as we go back to this, just think through some of the case studies that we had where you had to pick out like a person, if they were a smoker, if they were physically inactive. And these are things where you have to evaluate on page 1, or you can use this on page 144, where you can use this to help evaluate your client's current risk of cardiovascular disease. And it might be a conversation you have to have at the table, like, hey, by the way, has anybody ever said you kind of are at risk for cardiovascular disease? And they've never even had that conversation before. So with that, the book then goes into, get myself out of the way here, goes into the different medical conditions and diagnosed disease: cardiovascular and pulmonary disease, risk of sudden cardiac death, metabolic disease, orthopedic conditions, and medications. And we'll kind of break this out like this. So the ones in white we'll talk about right now, it's cardiovascular and pulmonary disease and risk of sudden cardiac death. So with that, these are signs and symptoms, right? And these signs or symptoms are right there on that 8+1, and you can see them on the bottom. You can even see them on the American College of Sports Medicine algorithm, and it's in the footer. They do a good job of this, but they note signs and symptoms of cardiovascular and pulmonary disease: pain or discomfort, chest, neck, jaw, arms, other areas that might be due to ischemia, which is a lack of blood flow, shortness of breath at rest with mild exertion, dizziness, which is syncope, orthopnea, paroxysmal, sudden or unexpected, nocturnal dyspnea, meaning shortness of breath, ankylodemia, swelling, tachycardia, elevated heart rate, intermittent claudation, known heart murmurs, unusual fatigue, shortness of breath with regular activities. So those are the things you're looking out for cardiovascular and pulmonary disease. When we get into risk of sudden cardiac death, Here's the thing. People who are physically fit, and they have it in here right midway through this passage. In fact, regularly physical activity is strongly advocated by the medical community, in part because of substantial, et cetera, et cetera, et cetera. Here's the thing though. Vigorous physical activity can acutely and transiently increase the risk of acute myocardial infarction and sudden cardiac death. So understand that when you're working with somebody, if they're physically fit, you have a reduction in the possibility of cardiac death, but also realize that when you have regular physical activity, it's maybe strongly advocated, got it, but the thing is, vigorous physical activity can increase the risk of an MI, myocardial infarction, and sudden cardiac death in susceptible individuals. And susceptible individuals I would broadly classify as deconditioned, perhaps at risk as per our 8.1 that we talked about earlier. So what you need to do is really have this health history questionnaire to help you determine if a person is at risk of sudden cardiac death. Do they have chest pain or discomfort with any kind of physical exertion? Do they have, any kind of excessive dyspnea? And then do they have syncope? Family history of sudden unexpected death before 50. These are all the things that are right there in that 8.1. Any kind of heart disease before 50 in a close relative, like a level 1 relative. And so when you start to have these conversations, though a person may have a note, though a person may have been instructed by their doctor to come in and start their fitness, if they have any of these signs or symptoms, then it becomes a conversation of have they had a stress test, and if they're cleared to come in and work out. Now you as a practitioner have to make the right choices in just how you work them. So in fact, you're not working on perhaps in vigorous physical activity. Maybe it's just generalized physical activity and you're being smart about it on the front end, so you don't have the possibility of a sudden cardiac death. Now we get to these last three: metabolic disease, orthopedic conditions, and medications. With the metabolic diseases, we're looking at diabetes, and it's important here, not only just from working with your clients, but it's also important for some quiz questions and test questions that you'll see. You have persons with type 1 diabetes are insulin dependent, meaning they require insulin injections to metabolize glucose. But type 2 diabetics, they produce insulin to a certain degree, but the tissues then are just insensitive to it. So what happens is you have the ability, both type 1 and type 2 benefit, no doubt. But what you see is almost like people with type 1 and type 2 diabetes, when they come in and see a trainer, they fully understand they are diabetic. They fully understand the risk components of their disease. And they will, frankly, unless you have diabetes, they'll probably be more an expert in it than you ever could be. And so to that end, when you're working with the client, you can articulate to them and say, hey, from what you're telling me, you're type 2 diabetic. I get it. If you ever have an issue where you're feeling not right, you need maybe to go sit down, or you have to go get something to drink, or whatever that may be, please feel free to do that. Because you want to articulate that to the person, and you want them to understand that you're working out is part of the process, but working out may tax the system to the point where they have to go get a little bit of juice, or maybe they even have to go get an insulin injection. It could be any number of different things that help to resolve the issue with the person. But what we know is diabetes is known to be an independent contributing factor to developing cardiovascular disease. So it increases the potential. It's a positively correlated factor. Now, it's an ongoing, right? It's a chronic type of disease, and it's something where, you have your precautions with your client. You're going to actually have those conversations with your client. But because it's a chronic disease, I'll say it again, your clients will almost certainly have themselves wrapped fully around the concept of being diabetic and how exercise actually plays into being diabetic. With orthopedic conditions and disease, this is not as big of a deal, but you'll definitely have some people who may have some osteoporosis, maybe osteopenia. They might be arthritic, and so as a result, they might have some concerns regarding osteoporosis and osteopenia. And being arthritic, they might have some aches and pains that you just either have to work around or work through. It's just the way it is. Oftentimes, it'll be a combination of when people come in, it's like they're sedentary, they don't work enough, they don't move the joints enough, the joints become stiff. I can use a real broad-based kind of non-specific professional term, but they end up needing movement. And it's kind of like motion is lotion, right? But at first, it's uncomfortable. And so they may have to actually work through some of the aches and pains on the front end. Make no mistake about it, if they have a true orthopedic concern, if they have diagnosed arthritis and they're on path to maybe having a hip replacement, that becomes a different conversation, because to them, what they're really preparing for is the surgical procedure to eliminate that background noise and the ache and pain that they have in their hip joint all the time. And to that end, the pain doesn't become as much of a limiting factor because they want the muscles nice and strong. So it just depends upon the person who's in front of you. Somebody who might have some orthopedic concerns, who might have arthritis, they may need to actually have extended warm-ups to be able to work on having greater synovial fluid and lubrication in the joints to be able to function better. But there's no doubt, it's going to be unique to the person. Medications. I can't stress this enough. When you're working with people, as they age, you're going to have different populations that are on medication. They could be on something as simple as, like, and I note here, like a beta blocker right here, a beta blocker for blood pressure, and that will affect heart rate. And you may push that person. And I think I've talked about my one client who's on a beta blocker. I can't get him over 85 to 90 beats a minute just because he's on a beta blocker. That's his ceiling. That's as high as I can go. And to that end, your clients will articulate that on the front end, and you'll be able to work within the confines and the constraints of that medication. But a client may come in and they may be on a particular medication. You might go, well, I'm not really sure what that is. You'll get better at knowing, like, antihistamines or beta blockers, alpha blockers, and things that are very common for like an older client base. But every once in a while, somebody will come in with something new, and I would urge you to then make that person the expert and find out as much as you can from that person regarding their medication, because they will be better and more well-versed in understanding whatever medication they're on more than you and I ever could be. And I would use that to your advantage. So with a lifestyle evaluation, oftentimes you'll see like dietary intake and eating habits, perhaps how they normally would exercise, and stress management. I'll say this, there's a relationship between many of the choices we make, whether it's what we eat, how much we move or don't move, and how we manage stress. I know we've talked in this class regarding trait and state anxiety and different types of stress that are on the body, and how some people process stress differently based upon their trait anxiety. And I'll just say this, when you talk with people and get to know different people, you get to understand in terms of their level of being able to process stress, and working out is yet again another stress we place on the system, on the human organism. So you as a trainer may have a client who comes in completely freaked out, been in meetings all day, and they have difficulty kind of keying into actually doing a great workout. And with that person, because of their personality type, they like getting crushed. They like getting hammered and throwing weights around and just chucking medicine balls and doing that kind of stuff. Whereas another person might actually benefit more from Pilates, yoga, flexibility, maybe foam rolling, and that's their mechanism to be able to de-stress or uncouple from a stressful day. So you have to key into the person to get an understanding. Some people love the banging and hanging, blood and guts training, while others like the more quiet and subdued, chillax mode to training, just to kind of pull down and get out of a sympathetic nervous system response and have their basically SNS down regulate. So it depends on the person. It really does when you come down to it. And it comes down to understanding your client and understanding their levers and basically understanding how you can program correctly. But on the front end, it comes down to, when you sit across a table from somebody, is having the conversation, a well-informed conversation from the health history questionnaire, to get a better understanding of the person's risk profile. All right, moving on to the next one.